So let's talk more about just the mechanics of the medical society, the organization itself.
The medical society, and this is what makes a society different from a private corporation, but I think our medical society different than most of the others simply because of our resources and our staffing. Our medical society is a volunteer organization. And our staff recognizes that. And they're more than willing to be available whenever the physicians are available. Emails, texts go out in the morning. They may not get answered till late in the night.
Right.
I received emails anywhere from 10 o'clock on in the evening following questions. The staff recognizes it's a volunteer organization and they go out of their way to make sure they're available when we're available. And I think that's what makes this medical society so effective. They're working by day with the community organizations and then filling everyone in on what needs to be done and what best practices would be and where we think we should go in regular daily meetings or nights, weekends, and holidays when necessary. And I see only willingness to be available everywhere. And since healthcare is very busy, and since physicians are very busy, we're probably going to need to change the way we do business amongst ourselves in our own professions. There isn't a Wednesday afternoon off anymore. The days are long. The hours are sometimes fragmented with working. Many of our physicians are now employed and are not masters of their own time. I think and our newer members, those that will be leaders in 5 to 10 years, the millennials, they're already there, work differently and think differently. You know, they've been brought up with the internet. They're very project oriented. They may not think about committee work being long, with long meetings as being as productive as they want. They may join a committee for the part of the agenda that's important to them and leave. They may have several other things to do, and it will be our job over time to find the right value mix to entice them, encourage them, and have them assume leadership roles. We may need governance changes and things, and I think we're at a nice point in our medical society to begin to look at where we really need to be in 5 to 10 years to engage newer members who have been raised on a very different diet of education. The internet, the ability to transfer information, to do remote studies, to have participation, not physically present, is very important. We're adapting to that. I think we're going to need to be able to do that, or we won't be able to engage the current generations coming along.
Right. So I hear you saying two things. One is that the public and other organizations have a lot of respect for the medical society because we're not perceived as an organization with an agenda of self-interest, but we have the reputation of basically trying to represent what is best for patient care. And so on the one hand, we've got that. On the other hand, we are evolving, and we're keeping that. If anything, we're gaining in our reputation regarding it. But the other part of it is we're exploring new ways to be more inclusive to our members, to allow the organization to draw in its members, to better understand them, and to better educate them.
Yes.
So that's how the organization is evolving right now.
Yep. And it's subtle enough so that if you don't actually sit back and think about it, you don't realize where you've been going. But the times have changed, as I noted. Participation is now more intermittent than it used to be. Very important to be able to address that. But the intensity of involvement and the intensity of interest is even more apparent. So we're looking forward to moving in those directions.
And in your role as president, we've talked about the hours being more demanding. At this point in time, with the year you experienced, about how much of your time was devoted to your duties as president of the Medical Society?
Well, I had the luxury of being able to scale back my practice. I'm an anesthesiologist to 50% time and then to 20 to 30% time. And the rest of the time was very filled with this. And I was was able to partake in a lot of this. I think in other years it might not have been as feasible for somebody to be able to be as available as I was. Speaking about availability and the medical society's ability to hold meetings remotely, there is actually no reason that anyone anywhere in the Commonwealth couldn't participate in any activity in the medical society. All of our committee meetings can be held and joined remotely. Doesn't make any difference whether you're on Cape Cod, the Berkshires, or up on the North Shore. It can take an hour to get to the medical society from downtown Brooklyn. From Brookline, Massachusetts. It can take an hour and a half to come from UMass. Significant distance. And I think what we'll find is remote participation. Our neighbor over here, Raytheon, does all of its worldwide business by the internet. And I think the medical society, we need to encourage people to participate remotely. Then neither rain nor snow nor sleet or hail will keep the meetings from happening.
Right.
And it'll probably be important for the chair of a committee and the staff to be physically at the medical society over the short haul. But I think as we move on through increased engagement in a wide variety of time commitments, remote participation will be the norm rather than something of interest. And I look forward to it. It'll be the only way we're able to get the work done.
Now, the way physicians' work is evolving, you alluded to that, and the fact that the picture of a physician, a clinician in solo practice, or a small group functioning independently is fading at this point in time, and we are seeing more and more people basically being employed by large multi-specialty groups, by organizations that are vertically integrated. Can you comment on how that has?
Well, I think having spent my career with a large single specialty organization, contracting with vertical systems and with horizontal systems, I can say that in my mind there are a few areas in which there are scant differences between a self-employed physician and a physician who is employed, because each one of those practice segments for the employed physician has to stand on its bottom line. And so a relatively inefficient office will certainly be a focus of attention in an employed physician's practice, regardless of the size or the remoteness. And I think that the medical society can help people think about individual practices, whether they're within a large organization or within a small organization. A lot of the tools and tricks that the AMA has developed with its practice management work, and through our professional practice PPRC, Physician Practice Resource Center, can be directed to employed physicians' practices as easily as they can be to independent practices, because a practice is a practice. It's tied together now with an electronic health record, and we certainly have seen the trials and tribulations of those. But as they become better integrated, they'll be the backbone of anyone's practice.
Right. And as we have this conversation, electronic medical records are in use in nearly every office. But there's a wide diversity of programs. They don't necessarily talk to each other. There aren't systems in place at this point in time to do significant public health monitoring. But patients are able to communicate with their physicians through the electronic patient portals, they're called.
That's right.
So that's kind of our status as we have this conversation. Hopefully people in future years watching this will have a much more sophisticated electronic record to
hopefully it'll be a lot more integrated. As you know, and as we all know, the Massachusetts physicians were among the first in the nation to be interested in an electronic record. The first disappointed and continue to be disappointed and disenthused by the lack of integration, the complexity, and the lack of interoperability with the myriad systems that are out there.
Right, and I'm told that one of the top reasons for physician burnout now is attributed to electronic medical records.
I think that's a very significant part of the problem.
So hopefully that will improve in time. And at this time also, as we have this conversation, the majority of physicians in Massachusetts are employed by larger organizations. Is that a fair assessment?
I think so. I think, and the medical society to that end, can direct lots of its educational resources so that the large organizations don't have to develop them on their own. You know, our licensing initiatives, our opioid treatment initiatives, education for substance use disorders. Those are, there are lots of background parts of this that are relatively universal. Speaking of that, I would want to make sure that I include the fact that as we developed our own standards, our own guidelines for the administration of opioids, we at the Medical Society worked with the Department of Public Health and the deans of our medical schools to develop a uniform curriculum, curriculum guidelines.
Yes.
For material that will be taught, however it's taught in each of the schools over the 4 years. We're now moving that kind of that kind of organization and presentation into the residency training programs as well, so that hopefully within a few years, people either educated primarily or trained in residency programs here within the Commonwealth will finish those programs with a standard education in opioid use disorders, the treatment of them, and the recognition.
So we've witnessed sort of the pendulum swinging. In the 1990s, the Institute of Medicine felt that patients' pain was being undertreated, and there was a broad move for physicians to treat patients' pain more aggressively. And then we've witnessed the opioid addiction crisis, much of it fueled by prescription opioids. And now the pendulum is swinging towards finding alternative methods of treating pain, of moving away from that, of realizing the unintended consequences, and trying to move practice in a different direction. And the Medical Society is a focal point where there can be communication with residency programs, with medical schools, and continuing education for physicians, so that if a transition needs to take place, it can occur at all levels as opposed to piecemeal.
That's right, and we've been very involved with the regulators, with our elected officials as well, with Governor Baker, with Secretary of Health, Education, Human Services, Sutters, and with our Department of Public Health leader, Dr. Monica Burrell, in working with the groups, getting groups together to develop and move forward on these initiatives, and we've been very successful with that. It's been very important.
And continuing education, I guess, is another big piece of the Medical Society's role.
We were very early on in that. We were one of the first state organizations to develop our own guidelines. They were subsequently adopted by the Board of Registration in Medicine and formed the foundation of what is now probably more than 20 educational opportunities around this. I note the development of a long-anticipated educational series on marijuana and marijuana use, addiction problems, and history, pharmacology, a regular course offered. I think it's going to be 10 or 15 parts, 15 or 20 segment courses. That is now the first segment of these. 8 or 9 are being offered through our Department of Education, which has been very, very important in moving physician education along.
Right.
We've gone from having some educational materials to having a wonderful variety that can be adapted by all of the providers, physician providers, their employers, mid-level providers, other organizations using the same educational material. It's easily adapted.
Right. So that's another important component of the service that the Medical Society provides. If we consider how physicians are educated, we're front-loaded. We have intense education for medical school and residency, and then after that, it is a little bit more piecemeal. Yet the pace at which medicine changes is such that within a few years, a physician is at risk for being out of date if they don't keep up.
As you had noted, the perfect storm of perhaps opioid overuse began with new medications, mandates from organizations that have since changed their names. The Institute of Medicine doesn't exist anymore.
Right.
It's the National Academy of Medicine.
Right.
Probably to separate itself from
Well,
from that. And
yeah.
what we felt, the medical society, the space for the medical society is in the postgraduate physician, and our education programs were sponsored and directed toward our postgraduate physicians, and we realized that we really needed to backfill primary medical school education and residence programs as well, and that's been the trajectory. Mm-hmm. The attention on the postgraduate physician, and then our work through our regulating agencies and our medical schools to teach medical students and take care of the undergraduate, and now the graduate physician in training, mm-hmm. so that we'll have a uniform exposure to the appropriate materials over time.
And the service we're providing, the research we're doing has to do not only with the topic and its content, but it also has to do with the methods by which we provide this education, we make it available.
That's right.
We're still including lectures at an education site, but we're also moving a lot more towards online education or things that are more self-assessed.
And I think to that end, I think simulators and
Mm-hmm.
simulated case scenarios will be the wave of the future. It will allow the physicians to customize their time availability. Mm-hmm. Many of these courses are taken on nights and weekends and holidays when physicians have time, and it's our obligation to make that material available. And I think the online variety will be much more important, as will be a movement to take our in-house educational opportunities and modularize them to be able to be accessed as an online teaching material. I think gone are the days where we can expect a significant group of people to come at any one point in time for a lecture series. Mm-hmm. And if we do, then we use that material to make it available to the people that can't, mm-hmm. with the same qualifications and abilities to fulfill educational requirements.
So let's back up a little bit from your presidential year. What other roles have you played in the medical society? What first brought you into the medical society?
Neighbors. Probably 30 years ago, when we moved into our neighborhood, a couple of senior physicians came up and said, you have to join. I'd been a medical society member. Are you active in the medical society? Active? Yes. You're coming to the Norfolk district meetings, mm-hmm. in Brookline. And peer pressure, I guess, interested peer pressure got me to attend some district meetings, and from then on, as interest developed, I found more committee assignments. I was the chair of the Committee on Finance, and on the Committee on Finance for a number of years, and yes. Found that a very good way to understand the highways and the byways of the medical society, and then got interested in all of the other work that the medical society does, particularly its public health initiatives, which mm-hmm. Are becoming more and more visible over time. They've always been incredibly important, and we spent lots of time on those. But this is where our interface with the public is, and I think this is where we get our traction with the public. We're not seen as a trade organization, as we might have been in the past. We're really seen as leaders in public health. What's good for our patients is important for physicians, and what's important for physicians is going to reflect on our ability to take care of patients. And I think that's that patient partnership. A license to practice medicine in the Commonwealth is really an obligation to improve the lot of our patients. And mm-hmm. I think that's a message that I heard years ago, and I think is quite important to remember.